right? To check lymph nodes. So really the only thing, and you'll find the reason why we asked you to palpate from behind is because that's the best place to palpate the thyroid. So you're already positioned behind the patient to check for lymphadenopathy, then you're already in position to palpate the thyroid. So it's all going to make sense. There's not a ton of things to add today, so this is going to go really quick. So just some things that you need to know specifically about the thyroid exam itself and the endocrine review systems. You guys can look at these later. And the bottom one, appropriately document the above. There's, as long as you know the words to use for endocrine abnormalities, just put that in your note if you see something. For the SPBL, the documentation is easy for the thyroid. So when you look at the neck, what are you already know to look for? Is the trachea midline? Masses, swelling. Pulsations of the JVD or the carotid. So you're already looking at those things. So this adding on, just looking for the thyroid is easy. So your endocrine review systems. This will become more intuitive as you get more Clin Med lectures behind you. Right now, some of these things may not make a whole lot of sense, but by the time you get through your module, it'll all make sense. Galactorrhea is one that is probably new to you guys. That's just leaking of what looks like milk from the breast, whether it be male or female, of a person who's not pregnant or not just had a baby and shouldn't be lactating. Again, diaphoresis, which is in your cardiology review systems. The two big history ones are, ask everybody, which you should probably get in the habit of asking all your patients. You have a history of diabetes, history of any thyroid issues. So they're in your endocrine review system. So if you forget to ask, the review system will catch it for you. Temperature intolerance, why would that be important? For thyroid, right? Thyroid helps regulate your basal body temperature. The 3 P's of diabetes, you guys, if you've been to Good Shepherd, you may have learned these already. Polyphagia, polydipsia, polyuria. You need to ask anyone you suspect might have diabetes, those 3 things. And sometimes that will already be coming out in the history. You know, they'll be complaining of being so hungry or extremely thirsty, drinking more water than they've ever drank before, getting up at night to pee 2 or 3 times, which is abnormal. So it can be confusing in a male that's over 70 years old because they get up at night because of their prostate. So you just want to ask about that. Well, have you ever had that before? You know, things like that. So, always ask any patient you suspect of an endocrine problem about any growth or development issues they had as a child or as a teen. Most people who've had growth or development issues are going to know and they're going to report that to you, but always ask. And then the hair, you know, we've had you pay attention to eyebrows, hair, whether the hair is coarse, whether it's sparse, whether there's patches of missing, whether they're growing hair in places they shouldn't be. The Greatest Showman, you know, bearded lady, you know, is the lady, I mean, that's a thing. I'm sure that you'll learn about polycystic ovarian syndrome later. I'm sure that was the bearded lady back in the day. Okay, who remembers the neck review systems? Because these two are so closely tied together. You're gonna have to be asked to elicit both in your SPBL. So, swelling we got,
limitation movement,
range of motion, goiter, mass, I think.
yeah, masses.
Okay, I'm not going to go through slide by slide by slide by slide of all the parts of the medical history, because you guys know this by now. So let's just talk about, if you were walking into a room to evaluate, let's just say a 48-year-old female who's coming in with fatigue. which is you'll learn to hate. You'll learn to despise the chief complaint of fatigue, because it could be anything. So you're already thinking something hormonally is probably going wrong with her, right? So what is the first thing? Just tell me some things in the HPI that you might be wanting to ask. And I just want to just kind of raise your hand and I'll let you speak. Stacy.
Are they still menstruating?
Are they still menstruating, or have they had any abnormal period changes? Definitely. Okay. Anything else? Anyone? Bueller? What else would you want to ask? 48-year-old female. She's tired. She doesn't feel good. What else would you want to ask to elicit something that possibly be endocrine? Amanda.
Weight loss, weight gain.
Absolutely. It's a big one. Change in weight, which is on which review systems? General. Okay. Who's somebody have one over here? No? No, nobody? Sleep disturbance. Yep. Have you been sweaty at night? Are you waking up with hot flashes? So we've elicited whether their sleep pattern's disrupted. We've elicited whether they've lost or gained weight. We've elicited if she's still menstruating or not. What else would you want to know?
Changes in appetite.
Definitely changes in appetite. Really hungry, which is polyphagia, or skipping meals, not eating. Is she depressed? Does anybody want to ask a psych review systems, like sleep disturbance would be part of that. Family history of depression. Have you ever been diagnosed with depression before? Temperature intolerance, again, is on your review systems. What else? What would you want to know? And I'll move on. What would you want to know about her past medical history that might help you figure out what's going on with her?
New medications.
New medications.
Family history of diabetes.
Family history of diabetes, or family history of any kind of thyroid disease, any kind of endocrine problem at all, definitely. What else do you want to know about her personal past medical history? Yes.
Has she had any thyroid problems in the past?
Right. Have you ever had thyroid disease, or have you had surgery on your neck? You know, did they disrupt something in the thyroid? Did she have thyroid surgery and they took parathyroids out accidentally, or any kind of neck surgery, chest wall surgery, anything that could alter the anatomy for sure. So definitely important to ask history of diabetes, history of thyroid. You'll be shocked at the amount of people that don't tell you, oh yeah, they told me my sugar was elevated before, but I don't have diabetes. Well, how high was your sugar when they told you that? Oh, it's just 300. You have to ask. You have to ask these questions. It seems silly, but you do. Somebody may have experienced this at Good Shepherd. Anyone? You have to nail them down and ask. Okay, so we know a little bit about her own personal past medical history. Has she had a hysterectomy, which we would have elicited probably when we asked about menstrual issues. We've asked the two important family history questions. Genetic disorders in the family, could ask that. You could always asking a female beyond just whether they're still menstruating, asking have you had children? That tells you they're hormonally things are working. If you haven't been able to ever get pregnant, then that should be a big sign that there's something possibly going on hormonally. So what do you want to know about her social history?
Has there been like a major change in her daily life?
Right. So did she change her activity level dramatically? Does she stop exercising? Has her fatigue affected her activity level? Again, we've already asked diet, but that kind of falls back in. And here's the thing about completing this full medical history. If you've already asked diet in the HPI and y'all talked about it pretty thoroughly in the HPI, you don't have to ask it again in the social history. Just document it there. It doesn't matter if you ask it there or you ask it here. You've already talked about it in your history of present illness, then just document it under social history, but you have to ask it all over again. The patient will appreciate that because it makes them feel like you're not listening if you're asking the same question over again that you've already talked about thoroughly in the HPI. Does that make sense to everybody? So you'll start getting better at just making those mental notes. What else do you want to know about a 48-year-old female that's coming in with fatigue in her social history?
Any just stress in general?
Yes, so I always like to ask, how do you cope with stress? How is your stress level? If you ask people, I have found, if you ask people how their stress level is, they're like, oh, it's fine, you know. But if you ask them, you know, what kind of things do you do to cope with stress? Do you, are you doing things that you enjoy? That'll sometimes bring more dysfunction out if they're able to talk about it in a different way. You definitely are going to ask her about drugs. I mean, is she an opioid addict that, is buying fentanyl off the street and that's really making her sleepy? So you're asking about your drugs. Always ask them about it. You're not taking anybody else. Are you using any other drugs? Find a way to weave that in without being accusatory. If they're having sleep trouble, ask, what do you take to help you go to sleep? Because what they're taking at bedtime to help them go to sleep may be giving her fatigue through the whole day. If she's hammering herself with diphenhydramine or Benadryl, give you half of the day hangover. All right. Anybody have anything else to add on the full medical history for endo? All make perfect sense, right?
Mhm.
It'll kind of start falling into place the more you get, the more clin med lectures you'll get. So here's the easy part, the physical exam of the thyroid. So your checklist for this SPBL is going to be similar. You got to do a focused head, neck, chest, lungs exam, but you need to pay closer attention and do more detail with the neck and the thyroid. So you will need to do all the lymph nodes again. When you're inspecting the thyroid, you need to look at it, and we'll get to this in a minute. You have to look at it from the front and from lateral, just like we did with the spine. You already know what to look for. We'll talk about the anatomy here, the landmarks here in a minute. Palpating, if you're palpating the lymph nodes from the posterior approach, you're going to be right there to palpate the thyroid, and we'll talk about that in a minute. Auscultating the thyroid is unnecessary unless there's a goiter. So it's similar to, the JBD. We don't really need to do anything with it. It's hard to do anything if it's not there. So you just need to verbalize that to your SP. If you had a goiter, I would auscultate it. And you can hear a brooding on a thyroid that's enlarged and hyperactive. So, inspecting, palpating, we're going to use posterior approach. You're going to palpate as they swallow. That we'll get into more detail on that in a minute and explain why. And then again, auscultating, we're not going to do it for the SPBL, but if you ever diagnose somebody with a goiter, listen for a bruit. That's a good thing to document in your note if they have a goiter, that there was or was not a bruit. Okay, you guys remember anatomy, right? That was a long time ago. Lots happened since then. So the biggest thing with the thyroid is that people often mistake that the thyroid lays right on the thyroid cartilage, and it's kind of a misnomer because it does not. The thyroid actually, if you can palpate your own Adam's apple, the thyroid is not there. The thyroid is below that. So you'll kind of want to feel for that notch, and you just kind of slide your finger down, and the thyroid's going to be about right there. It's much lower than you might think, because if you're looking at the Adam's apple, you think it's kind of, well, your thyroid should lay right on your thyroid cartilage, but it doesn't. So when you palpate from behind and you find the thyroid cartilage, I usually find it with my middle finger, and then those lower fingers are kind of right where your thyroid should be, and then you just kind of slide your hand down and it should be right there. So you should definitely know that thyroid cartilage is is not where the thyroid is. That helps you see it on an individual a little bit better. Also depends on the patient's length of their neck. I have a very long neck, so I have a lot of room between my thyroid cartilage and my suprasternal notch, but some people with very, very short necks, it's a lot closer. It's just the more necks you palpate, the more sense that will make. But the best way to identify it is find the thyroid cartilage. Again, I usually kind of palpate it with my long finger, and then your ring and pinky are kind of right where it should be, and then you just kind of slide your fingers down into the side. In both lobes. So I guess this is a thing. If you survive thyroid cancer, that's like that's their symbol. It's the blue butterfly. Has the thyroid shaped like a butterfly. Everybody remembers that from anatomy. So if you see a patient like that, you might ask, "Oh, have you ever had thyroid disease?" So it's advertising it. So what's abnormal about her neck? It is kind of subtle though. If you just saw her in the supermarket, you wouldn't know, It's fairly subtle, but you should see that there's just a fullness and enlargement. I mean, it is wide. Her thyroid is very enlarged. She doesn't really have any other signs of hyperthyroidism at this point, so it makes me wonder, maybe she's Hashimoto's or something. But once the thyroid's that full, it doesn't become as important to identify the landmarks, because you can clearly see that she has a goiter. You would definitely want to auscultate that, right? What you'll want to notice and note on the documentation as well is it symmetric? Does it or definitely perhaps not if it's normal. You could just say there's no thyromegaly, or there's no enlargement of the thyroid, however you want to document it. But if there's enlargement of the thyroid, you need to document whether it's symmetric or not. Which lobe is it in? Is it diffuse? The word people use typically is diffuse enlargement of the thyroid if it's bilateral and it looks like that. Again, we're looking too at the trachea to see if it's symmetric. It probably won't displace the trachea, but you can get enlargement on one side of the thyroid that's so large that it just kind of shifts the trachea over. And then ask the patient to swallow while you're looking at the thyroid. Okay, so if everything looks normal, just say and if it's a short neck person with more subcutaneous fat, just have them extend their neck a little bit. And I would, for the SPBL, you need to ask your SPs to extend their neck a bit while you're looking. They don't want to hold there the whole time, but just as you're inspecting, you're looking at it, okay, tilt your chin back for me just a bit, look, okay, thank you. Just have them put their head back. That's very helpful if it's shorter, bigger neck. You can also, if you see something abnormal, have them turn away, from you. You don't have to do that for your SPBL. I just want you to habituate having them tilt their head back a bit so you can see a little bit better. Then ask them to swallow. So, you're looking at thyroid, okay, can you swallow for me? Just have them do a quick swallow. Some patients that are extremely dry may ask you for a cup of water. If so, have your nurse get them a cup of water, or run and go get them a cup of water. But just know that that might be asked of you, but for the SPBL, they're just going to swallow. We'll have cups of water in there if they need them, because they're going to be swallowing a lot. So you've inspected from the front, you've inspected from the side, you've asked them to extend their neck a bit, you've noted any masses, fullness, goiter, tracheal asymmetry, carotid or pulsations or JVD. You've asked them to swallow, so now you need to palpate, right? Oh, here's your lateral. I put this slide in here because I wanted you to see how, you might not be able to see the enlargement of the thyroid from the front, but if you look from the side, you'll just see that little bit of a pooch underneath their thyroid cartilage, so just something to look for. So inspecting as they swallow, you don't need to do it from the front and from the side, just position yourself where you can get a good look. Why do we do that? Why do we have them swallow? That helps identify especially if you see an enlargement or you see a mass or a nodule, if you ask them to swallow, the thyroid should move with the cartilage. Okay, the thyroid and the cartilage are adhered to one another. So if you see a mass sticking out on there and you ask them to swallow, the mass should go up if it's attached to the thyroid, okay? And you guys can practice on each other just watching, but I have a fairly prominent, but as you swallow, it goes up. You know, and if you even have to pause a little bit, you know, it goes up to initiate the swallow and then drops back down. So it just helps you see if whatever you're looking at that appears abnormal is attached to the thyroid or not. If it's subcutaneous, if it's just a little lipoma or a node, if it's a lymph node, it's over here, it's a node, it won't move with the swallowing mechanism. So it just helps you kind of discern what you're looking at. Everybody can try that out on their friends and family. Okay. This goiter's a little bit more obvious. I mean, I don't even really know if you need to palpate that, but that's probably an iodine deficiency from someone in a third world country, but y'all learn more about thyroids in a minute. I don't know how you let it get that like that, but that's probably not, you're probably not going to see that in America much. Okay, so you already know your anatomical landmarks. We've talked about that we will teach you posterior approach. If you see something abnormal and you're out there in the real world and you want to palpate from the anterior, that's fine. But most of the time when they palpate from the anterior, you kind of use your thumb, kind of palpate the lobe, especially if you're really wanting to feel something you're seeing. You can palpate from the front. But for your SPBL, for the purposes of how I want you to habituate doing it all the time, you're going to palpate from the posterior. Okay. All right, so you're going to be really good at knowing how to palpate thyroids, but what are you palpating for? Who knows? It's on your slide. So first and foremost, you're palpating for enlargement, right? Whether or not it feels full or asymmetric, you know, it's more full on one side versus the other. Definitely for tenderness. Somebody with acute thyroiditis, you know, it's going to be uncomfortable for you to palpate it. The consistency of the tissue, I mean, I'm not sure. I didn't palpate a ton of goiters in my practice, so I don't know if I'd be able to tell you the difference between firm and soft. I mean, or what it would mean to me clinically. But again, as you palpate more, most of the time, to me, they feel soft. They just feel like the tissue, they feel like the same on both sides, and they feel like the other tissue surrounding it in the neck. It doesn't stick out and feel more firm than anything. If you were to palpate something abnormal, you might say it feels firm, more firm on the left versus the right, or something like that. Okay. It'll feel firm if you are feeling a nodule, and if you're feeling something enlarged on one side, like a malignancy. Again, that's going to feel different. It's not going to feel like the surrounding tissue. And then the texture, whether it just feels smooth. Most thyroids will feel smooth to you, and if you are able to palpate one, it won't feel nodular or bumpy. So that would definitely be an abnormality. So for your note, you could say, thyroid is palpated and it is symmetric. There is no tenderness, there's no enlargement, there's no nodules. Texture is smooth. I mean, that is a lot of information. But again, if it's normal, it's not as important to document all that stuff. Because if you're feeling something abnormal, you just need to know what words to use to describe it. Okay, so technique for palpating the thyroid, you're gonna, again, what part of our fingers do we use when we're palpating? You know, the pads of the fingers. Don't stab your patient with your nails. You're going to learn to keep your nails fairly short, you know, just so you aren't stabbing patients all the time. And then when you're percussing yourself, it kind of hurts, you know. So, gentle touch. You can actually push, well, 2 reasons. Why we want to push gently on the neck. Duh, number 1. So you don't make the patient feel like you're choking them. You want to keep your patient comfortable. So you don't want to get behind them and just, you know, put a firm grasp on the neck. That could be anxiety provoking. And it's probably a good idea too, especially if it's feeling really awkward in the room, you haven't really bonded with the patient, you just tell them, okay, I'm going to palpate your thyroid, so when I come back behind here, I'm going to put my hands on your neck, you know. For a normal patient that's just kind of, you've got a good interaction going on and they're kind and they don't seem anxious, then it might not be as necessary. But if you've got a real uncomfortable vibe going on, you may want to let them know that you're not going to choke them. People that have been abused, it is ingrained in their mind, and so just post-traumatic stress type stuff. So you want to let them know that, you know, what you're going to do. But again, use the pads of your fingers. Like I said before, I use my long finger to find the Adam's apple, and then those other 2. And if you let that ring finger go just beneath it, usually that's right about where you want to be, and then you just kind of slide one finger over and match the other one on the other side. And you just kind of gently palpate. Just kind of slide your fingers over their skin. You know, it's like sliding the skin over the thyroid. You don't have to deeply palpate at all. It's almost gliding or drifting over. After you've palpated it a little bit and it feels normal, then leave your fingers on their neck and ask them to swallow. And you just feel if you feel any abnormal rise or asymmetry in the thyroid. Okay. Does anything glide up under your finger, or does, you know, the swallowing is more helpful if you're feeling a nodule, but you need to do it on every patient just to be sure that it's rising and falling symmetrically. Just another check mark on your list that the thyroid is normal, that it feels normal when the patient swallows. So also when you're palpating, you want to habituate, and this is more important if you're feeling something abnormal. Have the patient just look to the left so you can feel the right very well. Have them look to the right, you can feel the left. So especially if you're like, ooh, I feel a nodule or something. Have them look away from the side you're palpating and just see if that gives you a little bit more, kind of brings the thyroid out to you so you can try to really hone in on that nodule if you're feeling something abnormal. Then you may need a second swallow. And swallow again. So it's just depends on what you're trying to hone in on. Anybody have questions on the technique? No, it's easy. I mean, even in GI, I did this on every single patient that came in, because it's just quick, easy. You're already kind of palpating for lymph nodes. You just quickly check their thyroid. I mean, it's like that fast. No. Okay, the thyroid. What is normal when you're palpating a thyroid? You may not palpate it. And if you feel like, oh, I don't feel a thyroid, it just feels like a neck. Well, that's okay, it's normal. So don't expect every time you palpate a neck to be like, that you could describe in centimeters the diameter and length of the thyroid, you know. If you don't feel like you palpated anything and you didn't feel anything rise and fall abnormally under the swallow, then that's a normal thyroid, okay? The lobes should be small. You should really not be able to palpate it, okay? The texture should be smooth. It shouldn't be tender. The lobes should be symmetric. They should rise and fall symmetrically with the swallow. The textbook will tell you that the right lobe might be slightly larger than the left. I've never noted that in practice. So what is abnormal? enlargement, which we call what? Goiter. If it feels coarse or gritty, that's just something you have to palpate a lot to feel like, okay, that's what coarse or gritty means, you know. So it's one of those things you can't really, I can't give you that experience of palpating a gritty thyroid until you just finally do it in practice. Nodules are a little bit easier to understand. They're going to feel like a little bump under the skin. Asymmetrical lobes are abnormal and tenderness is abnormal. Okay. Every time. Who has messed with this? Volume's up. Volume's up on the computer. I don't know where else to do it. Your sound.
Individuals, the thyroid only weighs around 18 to 25.
You weren't awake, now you're
Thyroid examination. Examination of the thyroid gland starts with inspection. In doing so, it's important to consider the gland's anatomy and its surrounding structures. The thyroid cartilage is a helpful landmark, since the thyroid can be palpated bilaterally below it. In healthy individuals, the thyroid only weighs around 18 to 25 grams and should not be visible. An enlarged thyroid, otherwise known as goiter, is considered class 2 if macroscopically visible. When the head is reclined, thyroid enlargement can be seen even earlier. Palpation is usually performed from behind, although anterior palpation is also feasible. The gland is often only detectable upon palpation if a pathology is present, such as nodules, enlargement, or an altered consistency. You should also note any tenderness to touch, as seen in inflammatory changes, such as a viral infection. To assess the mobility of the thyroid gland, ask the patient to swallow and offer a glass of water if necessary. If thyroid perfusion is increased, like in Graves' disease, examination may reveal an auscultable bruit and a palpable thrill.
Okay, so let's talk about some abnormalities. You already know what a goiter is. You need to, and here I wanted to show you this picture because that one's asymmetrically enlarged.
Nice to meet you, Simon. Today I'm asked to examine the thyroid gland in your neck. Would that be okay?
Kidding me. You too. Killing me.
What? Well, not that one, but like this background. He's like,
Now,
okay.
how do you estimate how big the goiter is? You heard him mention class 2. If it's class 2, it's palpable. We're not going to ask you to classify goiters. Just, do they have a goiter or they don't have a goiter? Is it symmetric, is it asymmetric? That's sufficient, okay? If you ever go work in endocrine, your physician may want you to classify them a little bit more specifically, but for our purposes, you don't need to do that. You can use the rule of thumb if the lobe is enlarged, larger than the distal phalanx of the patient's thumb, then it's enlarged. I mean, that's a way some providers do it. You can estimate by volume. I don't use that. These techniques are there for you if you want to use them, but I am happy with you just knowing if it's enlarged or not. Okay? I'm not going to ask you to tell us the volume of the thyroid, so relax. Again, auscultating is only helpful if there's a goiter present. Maybe the bell is slightly better than the diaphragm. It really, however you can hear it, whatever you want to use, it's your choice. You're not going to do it on your SPBL anyways. You're not going to be counted off. You just need to verbalize that you would auscultate if the patient had a goiter. Thyroid nodules, again, they're pretty self-explanatory. You're going to learn how to work those up, I think, today. But they're just going to feel like bumps. It's nothing more scientific than that for Phys dye. The most important thing is to note whether it moves when the patient swallows. If it moves when they swallow, it is attached to the thyroid. Okay, so we're done with the exam portion. We're just going to talk a little bit now about how patients with thyroid disease present, how they look. This lady's got bad myxedema. She was in my textbook when I was in school, so her face is in a lot of medical textbooks. They get enlarged tongue, macroglossia, if it's really bad. So if a patient presenting in a hypothyroid state, they're going to have edema. We call it myxedema. It's basically accumulation of these mucopolysaccharides. So they bind water up and they kind of get in the extracellular fluid and create this edema. It's not the same as like a pitting edema from like vascular, okay? That edema goes away when the patient lays down, gets back up, starts their day over, edema accumulates throughout the day. This is a more persistent edema. Maybe it doesn't go down the next morning, okay? They'll get this kind of swollen, puffy bags under their eyes. Although some of you come in with those in the morning sometimes, it does not mean you have hyperthyroidism because you're tired. You didn't sleep well. Their hair is coarse, thin. Their skin might have a kind of a yellow tint to it, not jaundice. It's not due to bilirubin. It's due in part to some type of metabolic issue they have with a baby and they get yellow skin from eating sweet potatoes and carrots. They kind of get that little orange nose. It's kind of that similar type of thing. Little yellow tint. They're cool. Their skin might be cool, dry, kind of flaky. You'll see these patients and you'll learn to recognize that type of skin. Most common cause of hypothyroidism is Hashimoto's thyroiditis. This female patient, I thought this slide was good for you guys to see how she looked before her hypothyroidism was corrected, and then her normal face. So you can kind of see the swelling, the eyes, kind of the bags around the eyes. Her hair didn't change a whole lot, but she just looks better, you know. These people, if their hypothyroidism gets bad enough, they can actually get delayed reflexes. They'll get kind of slurred, heavy tongue kind of speech, which is called hypothyroid speech. I've never seen that in practice. But a good point here is obesity is no more common in hypothyroid patients than in euthyroid patients. So you're going to hear that a lot. You know, I'm here because I've gained 50 pounds this year. I want my thyroid checked. Probably not thyroid. But you check it anyways. You're a good provider for your patient. Now, a little bit more fun to look at is the Graves' disease patients. So hyperthyroidism. Everybody, we talked about exophthalmos and general and head and neck, right? Oh, she's scary. But they get this just really intense stare, you know, with the exophthalmos. Their eyes are just, they get the lid lag, you know, their eyes kind of, their lids open wider. If you have them, gaze down, their lid won't follow, it'll just kind of stay up. They just have that kind of bug-eyed appearance. It should be bilateral if it's due to hyperthyroidism. If they've got asymmetric exophthalmos or proptosis, then that's not Graves' disease. It's probably something behind that eye. Most of these patients have a bruise. So they will also get pretibial mixed edema. So you get generalized mixed edema in hypothyroidism, but you get pretibial mixed edema in Graves' disease. Okay. Or thyrotoxicosis of some kind. Very overactive thyroid, you can get pretibial mixed edema. These patients actually get kind of a plaque, erythematous plaque on their anterior shins. That is on tests, that's on boards. That will be a Graves' disease question at some point for you. Again, more pretibial mixed edema. You'll just see with the hyperthyroid states, it's just very localized just to the anterior shins, and I have no idea what the pathophysiology is behind that. But it's a good clinical finding to be aware of. And then that's actually amazing, her corrected exophthalmos, just from treating an overactive thyroid. So they'll get the opposite. So hypo will get delayed reflexes, hyper, they'll get brisk, hyperactive reflexes, fine hand tremor. They might complain of palpitations, they may have tachycardia. They'll also present, they don't come in presenting with all this extra energy and they feel great. They come in exhausted because their body is just running them ragged. Okay? They don't come in feeling real good. Now, after you correct hypothyroidism, they'll come in a little bit hyper and they'll feel kind of good. But these patients with Graves' disease and pathologic hyperthyroidism, they feel horrible. Okay, so some other endocrine disorders that you guys will get. Have you had mostly just diabetes at this point? Okay, so you'll get these other things coming up here. You need to know how to recognize Cushing syndrome. You'll hear about this at some point. This is high cortisol levels. It's an adrenal problem. You'll hear things like moon faces, buffalo hump, wide purple stretch marks, big, heavy, pendulous abdomen, lots of central fat. So they might have little tiny skinny arms, no muscle in their legs, but then a huge apple abdomen. Their skin's like thin, kind of papery, pale looking, and then they'll get the supraclavicular fat pads right here. They just start to accumulate fat right above the clavicle. And these patients will have acne as adults. So, just some good Phys dye things to know for Cushing. So adrenal insufficiency, or Addison's disease, these patients present bronzed. They've got like a tan, bronzy skin. They might have patches of vitiligo as well. They'll get loss of body hair, and then the advanced findings, you'll see that they got hyperpigmentation in their gingiva. So see, we have you look at their gums, so that's another reason to look at the gums. And now you're getting so smart, you can say no hyperpigmentation of gingiva, but you don't need to document that. But you need to know if you see that someday that that person could have Addison's disease. And you'll learn more about Addison's disease. A couple of things about hypoparathyroidism, which I'm sure you guys will have a lecture on the parathyroid gland at some point. But there's two clinical things that are probably going to be on boards. Trousseau's sign. So it's bizarre. You put the blood pressure cuff and you inflate it, and their hand curls up like that. And then Chvozek's sign. I have no idea if I'm pronouncing that right, but that's how I pronounce it. Facial nerve twitch when you percuss the facial nerve on that side. So they'll kind of twitch on that side of the face when you percuss the facial nerve. Where does the facial nerve come out? No, Dr. McNeil? No. So, hair loss, cataracts, papilledema can also happen in hypoparathyroidism. So know those old big guy names because they might be on board someday. And you guys know nothing about hyper or hypoparathyroidism yet, right? No, not much. This one's kind of interesting. And this diabetic neuropathy, long-term and poorly controlled diabetes will get these stiff hands. So you can actually, they won't be able to put their hands down all the way. And you ask them to put their hand in a prayer, and their fingers won't flatten out. And then you'll learn more about acanthosis nigricans. Did y'all talk about that with insulin resistance and things like that? Okay. Has anybody seen that on someone? I mean, often it's right here. And it just looks like they're dirty. It looks like you should be able to wipe it and it should wipe off, but it's not. So now you know if you see somebody and they kind of heavy and hairy and they have that dirt look right around their neck, it's not because they didn't bathe. They probably have acanthosis nigricans. They'll get it too, like in their armpits, right here. In the folds, it's where it happens.
How do you tell the difference like on darker skin people?
Well, it's actually more common in darker skinned people too, so it's more of a feel. But it's most of the time it's darker than the surrounding skin, but somebody who's extremely dark, you probably can't see it. It's more like a texture thing. You see a male patient that looks like that, they've got gynecomastia, okay? You need to know your differentials for gynecomastia. I think Dr. Donetta may touch on it in his hypogonadism lecture that he's going to give for you guys. So chronic kidney disease can do that to people, cirrhosis. There's multiple different drugs that can do it, which Dr. Latassi, I think, will cover that. Hyperthyroidism, hypogonadism, testicular tumors, and some type of ectopic production of human chorionic gonadotropin hormone. So the hormone of pregnancy shouldn't be high in a male patient, right? If it is, it's gonna give them a pregnant lady's chest. And then tumors of the adrenal gland can do it, so. You don't memorize this list, just, the most common thing is gonna be a man with some type of hypogonadism syndrome of some kind going on. You just need to know it's tied to that, and possibly tied to HCG overproduction somewhere. All right, questions? And it's an easy one. Didn't need 2 hours for this, thank goodness. I'm not awake yet, so. All right. No questions? All pretty self-explanatory. It's a very easy exam to practice on people. Do you guys want me to see, you want me to show you just kind of how I would do it? Guess what? Sit right here. So, if you're already behind the patient, right, because you checked the thyroid, you checked all the lymph nodes, right? So you're going to find her Adam's apple, which was right there. Kind of short. So just lift your chin a little bit for me. There you go. So her thyroid's going to be about right there. You can feel her trachea. And then her lobes would be just lateral to it. I just kind of shimmy up, shimmy down along the trachea. Just kind of palpating very gently, and then have her swallow. Everything feels normal. You don't have any thyroid nodules. Okay, tilt your head to the right for me. Yeah. Good. Now the other way. Feels normal. It's easy. Easy peasy. Easy peasy. You can do it on every single patient that you ever encounter if you want to.